EKG interpretation. An EKG reading starts with looking at the whole picture first, then systematically read as follows. Standardization, rate, rhythm, axis, T-wave, TR interval, QRS complex, QT interval, SYN segment, T-wave, U-wave, standardization. See if the EKG is set to the standard gain, 1 MV equals 10 mm, 25 mm per second. If the P-wave and QRS are negative in lead I, suspect the wrong lead. Rate. If regular rate, divide the number of large cells between the R wave by 300 or the number of small cells divided by 15 if the rate is irregular. Count the number of R waves in 10 seconds, which is equal to the length of a regular EKG paper, and multiply by 6 for the 1 minute rate. If lesser than 60 divided by min, it is called bradycardia. If greater than 100 divided by min, it's called tachycardia. Rhythm looks at 4 things. Is there a P-wave? Is the QRS complex wide or narrow? What is the relationship between the P-wave and the QRS complex? See if the rhythm is regular or irregular. Can be read out 4 ways. 1. Sinus rhythm equals normal P-wave axis precedes the QRS complex. 2. Sinus rhythm with ectopic beat. The atrial premature beat has a P-wave that has a different shape from the sinus P-wave and intervenes just before the next normal sinus. Premature junctional beat looks like junctional escape beat, but PJC intervenes before next normal sinus comes, but junctional escape beat occurs. Follows the long pause of the sinus node. PVC is a broad QRS complex, oddly shaped due to ventricular depolarization. PVCs that do not undergo the conduction pathway are often followed by prolonged compensatory pause. Characteristics of PVCs that are susceptible to VT, VF include frequent PVCs, group PVC greater than 3, multiform PVC, PVCs falling on T setting. Avami. 3. Reentrant rhythms and ectopic rhythms, such as paroxysmal supraventricular tachycardia, atrial flutter, atrial fibrillation, multifocal atrial tachycardia, ectopic atrial tachycardia, VT, AV junctional rhythm. VSVT AVNRT retrograde P-wave, rate 150-250 divided by min. Atrial flutter reentrant circuit around the tricuspid valve annulus flutter wave most pronounced at lead. 2. 3 rate 250-350 divided by min most common AV block 2 to 1 block. Atrial fibrillation caused by multiple reentrant circuits has a baseline of fibrillation waves and no true P waves are seen. VT is more than 3 non-contiguous PVCs, rate 120-200 divided by min, slightly irregular. Idioventricular rhythm is a wide QRS complex, rate lesser than 50 divided by min if rate 50-100 is called accelerated. Idioventricular rhythm, no leading P wave. 4. Heart block, QRS axis, usually between -30 and +100, determined by lead I and AVF with reciprocal lead. Please subscribe for more video. Thank you.